Good morning, India, and good evening in USA. Welcome to the Global Council for Ayurveda Research Journal Club meeting, which is held monthly. Today we have Dr. Asmita Wele joining us from Pune, India. In a minute, I will introduce her. But before that, a very quick, short introduction of the platform that is hosting this conversation today. Um, it is the Global Council for Ayurveda Research. We are Boston-based nonprofit, but we also have a sister chapter in India, which is called Ayurveda Anusandhan Abhiyan Foundation. Feel free to check out the website. It is very simple, ayurvedaresearchusa.org. So three very simple words, ayurvedaresearchusa.org. As you can see here on the this top of the screen, you see there is an India flag and there is a USA tab. So depending on whichever country you are checking out the website from, you can either click on USA or India and check out every tab. If you can become a member, it is very, very nominal to join as a member. You will get access to many additional resources on the website. As you can see, our mission is to encourage, educate, and facilitate basic clinical and interdisciplinary research in Ayurveda. And our vision is to promote and establish Ayurveda as an evidence-based health science globally. And mostly what we are trying to do is research literacy. So we have a chapter in India, as I said, and we are originally registered in United States. So please check us out. As you all know, that research is very important and critical to establish Ayurveda globally as a credible, authentic science of life. And no matter how we are defining research as, because research can be defined, needs to be defined differently for Ayurveda. No matter how we define it, but some kind of revalidation is required for us to build bridges and to be able to conduct multidisciplinary and transdisciplinary work. So with that, I'm going to welcome Dr. Asmita. Thank you for taking the time and joining us for this critical review of a published study, which is what we do in the Journal Club meeting. We follow the IMRAD template, which is nothing but introduction of the topic and then materials and methods, results, and then discussion, followed by conclusion and limitations. So that is what Dr. Asmita will be doing for all of us today as a learning experience. So a little bit about Dr. Asmita Wele, and then we will start the Journal Club meeting. Professor Dr. Asmita Wele is the Director of Research and Professor at the College of Ayurveda and Research Center at D.Y. Patil Vidyapeeth, which is deemed to be the university in Pune, India. She successfully completed her 3-year tenure at Hungary as chair professor and has been awarded honorary professorship at University of Debrecen, Hungary. She's a member of Pharmacopoeia Commission of Indian Medicine and Homeopathy, and has completed projects with DST and Ministry of Ayush, designing and execution of research projects of various types, guiding master and doctoral students is a part of her routine activities. She's often invited to be a PhD referee for RMT University, Melbourne, Australia. She has published over 50 research papers, articles, chapters, and also authored a book on research methodology for Ayurveda. She's a reviewer for some index journals from Elsevier, Scopus, and PubMed databases. She has been the associate editor of Journal of Ayurveda and Integrative Medicine India and Journal of Natural Health Product Research, NHPRS, Canada. So with that, I welcome Dr. Asmita Wele, and I just missed adding one thing about the G card, which I will quickly share, is that we are like any other nonprofit. We are looking for volunteers for our various projects and committees. And we also, like any other nonprofit, we are always looking for donations to be able to survive and just maintain our website, etc. So anybody who's listening in right now or listening in later through the YouTube video, this recording will be uploaded on our GCard YouTube channel to watch for free. Please consider donating as well as joining. And with that, Dr. Asmita, the screen and the stage is yours.
So good morning, India, and good evening, US. Thank you, Dr. Pratibha, for inviting me for this wonderful session. It's always, learning for me when I have to present something, I have to discuss and talk on various platforms. So thank you very much for having me once again at G-Car.
It's GCard now.
It's been almost over a year when we last, did one of such activities. I hope my screen is visible.
Yes.
Okay. So we are good to go. See, this journal club activity is very, very important, and it is taking shape in India in a very few premier institutions now. Dr. D.Y. Patil University is one of such institutes who has really put emphasis on Ayurveda research, and they are supporting it wholeheartedly by providing various opportunities like seed money projects, and then putting in a system to encourage the faculty members and students equally. So while starting this journal club today, I would like to at the outset make it very clear that this is a disclaimer. This particular study is chosen only for the purpose of learning and education. So no, we do not intend to do any favor or cause any harm to the study, to the participants, to the places where the study has been conducted. So after the disclaimer, let me say that this is one of the best studies that I have across, which is using the whole concept of Ayurveda, and we will look into the content in introduction, methodology, inclusion, exclusion criteria, interventions, outcome measures, the methods of statistical analysis, and finally what this study has added, the new knowledge that it has added in the domain of particularly Ayurveda as well as modern science. If you all can see, just give me 1 minute. I want to. If more, I want to put this panel on the. No, it's not happening. Pratibha, can you help me doing this?
What do you want to do?
No, I want to do, just keep a, on this right hand side of my slide, I'm seeing all of us, which I don't want to see, those who are present and all.
Oh,
So,
you can click on view and let me see. I can do it for myself. Are you able to like extend now? Is it better? So there is a
view,
on this.
no, but it's okay.
I think it's on full screen. We are able to see. So please proceed.
Okay, good. So about this journal and article, it's very important whenever we want to, like you said, that we want to have this evidence and importance of Ayurveda and bridging the gaps in between the traditional knowledge and new knowledge, and with the extension of whatever new technologies we get, we must be able to achieve or to bring evidence to the science of Ayurveda. So this particular journal, Osteoarthritis and Cartilage, is the journal in which this article has been published. This journal belongs to the Osteoarthritis Research Society International. It has been running for quite a few long years. This particular volume in this, the article is published, is the 26th volume. Now we are into the 33rd volume. So 5-year impact factor for this journal is 7.2. So indexing in Scopus, PubMed and Embase, these three major indexing agencies have, indexed this journal, and that talks about the quality of the research work indirectly. And that's where
Asmita,
we go
can
ahead
you
with good
can you
quality journals.
sorry to interrupt, but could you, for our listeners, also explain the impact factor? What does it mean? Like 7.2, what does it indicate?
Oh, yeah. Impact factor is the factor that means the work which you have done is consistently referred and read by by people, and the journals, all the articles, not only this article, but all the articles are read and referred and cited by the intelligentsia, people who are in the core science field. They value this journal, and therefore it is 5-year impact factor. Generally, impact factor is calculated every year, and then it is calculated at 5 years. So the more value is for consistent 5-year impact factor. Impact factors of good impactful journals, generally when there is an agency which calculates all these impact factors, Cymago and others. So when they calculate these impact factors based on the citation indexes, and this is a AI based process now, it's not a human based process, so there is no interference, there is no partiality, so it's a AI based process. And then therefore there is very little room for any thinking or doing something because we are good, you are not good, like that. So therefore this part is very important. The title of this particular article is Effectiveness of an Ayurveda Treatment Approach in Knee Osteoarthritis, a randomized controlled trial. So after reading this, we get to know that there is a condition, knee osteoarthritis. So osteoarthritis can be of many joints, but here very specifically only knee joint. Then we also understand that it is a randomized controlled trial. So there is the whole process of randomization is followed, and then effectiveness of Ayurvedic treatment approach. So we are not saying any particular drug or only a procedure or something. It's a whole protocol which includes drug, which includes procedure, kind of panchakarma, which also includes lifestyle, and it also includes some exercise or yoga based models or therapy. I want to draw my listeners' attention to the researchers as well. He is Dr. Kessler, then Professor K.S. Dhiman, then Abhimanyu Kumar, then Osterman, then S. Guptaji, then M. Mittavede, Steppelfeld, M. Spoo, E.K., A. Michelsen, and C.M. Witt. So C.M. Witt is the professor. She is attached to the 3 universities, 3 different schools of medicine: University of Maryland School of Medicine, where she, in the Center for Integrative Medicine, she is a professor. Then she is also associated. These things are available in in the modern medicine and Western world, that at the same time you can have different hats, and with all 3 hats you can work for for different projects. So she is also associated with Emmanuel Hospital Berlin, and then she's there with University of Witten, Herdecke, Department of Psychology Psychotherapy, Witten, Germany. So she's the main project in charge for this particular project. And if you see, the project took place, this was a funded project, So this took place from Germany, India. All the best brains came together, and then from India also the CCRS was involved. Shivashankar Guptaji from Nadiyad was a part of this particular project, and at that time, Professor Witt was working from all her hats, and she was basically in Germany. Christian Kessler is avid. Uh, if I use the word fan, a very much interested person in Ayurveda, and he has devoted his 15 years of his career into Ayurveda, and he presently works from Charité University in Berlin. So how they looked at it, what important factors they looked for, and how precise they are in their introduction. So osteoarthritis, it is a global relevance. I remember 10 years ago it was all about angioplasty and putting in stents, and now everything is about knee replacement. If you have seen the changing trend over past 5 years, knee replacement has become, you can just hear it even in India. There is a knee replacement because there was degeneration. So up to 250 million people they suffer from this osteoarthritis, and this is why they have selected this disease. Then World Health Organization recommends to include traditional system of medicine in global healthcare. That is the second reason why they wanted to work with Ayurveda. Third is Ayurveda is a regulated and system by independent ministry. That's the third main important reason why they wanted to take up this work. And the fact that they identified is that 33 Ayurveda studies showed that most trials, that is 91% of the trials, evaluated herbal preparation interventions, but not a single trial, even from India, evaluated the multimodal approach. So when I say that it is about the drug, it is about some panchakarma procedure like abhyangam or yoga or lifestyle modification, some diet, then it is called as a multimodal approach for a particular condition. And here, in case of modern treatments also, by conventional medicine, there is a multimodal intervention. They also, in the conventional medicine, also pharmacological. So there are certain drugs which are basically analgesics, and they use certain therapies, some physiotherapy, exercises. If the cause is obesity, then they try to do the nutritional assessments and advise the patient to reduce their weight. And therefore, this particular congruence is put in this paper or in this study to bring the two sciences together for research. This is one of the best examples of study design. They did randomization. Allocation is 1:1. So one patient for Ayurveda, one patient for conventional treatment. Ayurveda treatment 15 sessions, conventional treatment 15 sessions. Both the treatments started at week 0. Intermediate evaluation was done at week 6 and week 12. And then the follow-up was done for consistent 1 year. One intervention or one follow-up was at 6 months, and the next follow-up was at 12 months. So here you can see there are main outcome measures. At the beginning of the study, it was decided as WOMAC global index, then the use of rescue medication for both the groups, which was same, which was a standard medicine, analgesic, and then participant diary. So based on this, to check how they have maintained their lifestyle and the modalities which are told to them, how they are recorded. And then the secondary outcomes were WOMAC subscales for pain, then the profile of mood states, then pain disability index, then the 36 short form 36 health survey, numeric rating scale, a Likert scale for a time point assessment. So all that they have done. In this study design, how precisely they have presented patient enrollment from October 2010 to January 14. And then the study intervention is from November 10 to January 15. Why they have done this, we will see. January 14, last patient was enrolled, and then from there calculate 1 year. So that is January 2015, they have completed the study. And in October 2010, they first announced their study in the newspapers for enrollment of the patient. So this is a multi-center open label trial, randomized participant. The randomization technique used is equal block randomization with block size and stratified for study site. There are two study sites. One is Emmanuel Hospital and another one is Charité Hospital. Both the hospitals were in Germany. Outcomes were assessed at baseline 6 weeks, 12 weeks, 6 months, and 1 year. That I explained on the figure also. Participant received the same thing which is explained on the figure, which is written here just for reiteration. Long-term effects were assessed at 6 and 12 months. Why? Because it happens particularly in case of analgesics. Whenever there is pain, you take analgesic, the pain subsides. But whether that effect sustains for long or not, and whether Ayurvedic treatment has something to contribute at that particular aspect, that has been studied rigorously in this particular work. There are statisticians, data entry personnel, and funding source were blinded to treatment. That means they did not know what kind of treatment is being given to which groups. So therefore, there was a complete isolation of data entry, and thereby the results become more reliable. There is no tampering with the results that, okay, this is a whole system Ayurvedic study and then some positive results should come. It was not like that. The trial was registered at clinicaltrials.gov under NCT. This is the number, and it was approved by the University Ethics Committee, Charité Medical University. The ethics approval number is given. In many of the trials which we do in India here, maybe in institutes or academic institutes mostly, we have been practicing registration at CTRI, and we have been practicing ethics committee, getting approvals, but sometimes we miss mentioning it in the trial reporting, so this must be done. Participants provided written informed consent before taking part, and were not refrained from the participation. Now, just give me a second.
Any issue?
No, I was just checking whether I can move this window. Okay. Yes, so 70% of the participants were recruited via the newspaper advertisement. Participants were recruited by physicians from the trial center. So they have mentioned how they started with the recruitment procedure. Whatever we do, whatever process we have to mention it very clearly, and that they have done. These participants were pre-screened over the phone and, if suitable, scheduled to an enrollment. So in routine practice, we follow all these systems. What is important about this trial, which I liked, and I want to make it a point, that they are documenting anything and everything what they have done for the trial. So it's completely open trial. Then equal block randomization with variable block size and stratified for study site was done. Independent statistician generated a randomization list using a SAS software. The version is also described here, 9.1 and all. The data manager transferred randomization list into a secure database. where the randomization list was not accessible to anyone else. So no one could, why this is done? This is done to avoid the bias. So a person who is presenting with little less symptoms should go into the study group and the other in the conventional group, or vice versa. That should not happen. So the randomization should happen as per the statistical rule, that everybody gets equal opportunity, and that was followed by this particular procedure. Each participant could be registered and randomized only once. So once you are in the study, you are in. If you, by any chance, if you have to go out of the study, you are out. You cannot come back again, and that care was taken here. So statistician, data entry personnel, and funding source, they were blinded throughout. Now here inclusion criteria. So participant any or either sex, male or female, 70. So here see, osteoarthritis, degenerative change, it does not appear before you age, and sometimes it comes at a little lower age also. So they have set the lower limit at 40, upper limit at 70, because we do not want to enter into further complications. So we want a particular type of patient category to see the effect, and that has been confirmed here. NEOA pre-diagnosed by an orthopedic surgeon or radiologist according to the American Council of Rheumatology criteria. There is a particular criteria, and this test is done only for recruitment. It has nothing to do with the assessment scales. Radiologic changes in X-ray or an MRI. So both the gradings are listed. Mean baseline pain intensity in the affected knee of 40 mm on a 100 mm visual analog scale. The visual analog scale also, they have not used the pictures or smileys. They have used very typical 40 mm to 100 mm visual analog scale over 7 days preceding enrollment. Before the enrollment, the person must have pain for 7 days at least. Only those people, they have enrolled into the study. Now, exclusion criteria. Knee pain could be caused by n number of other things, which they have excluded. So it is caused by congenital dysplasia, rheumatoid arthritis, autoimmune diseases, malignancies, knee surgery, knee arthroscopy already which has been done. They have excluded it. Administration of chondroprotective drugs. People are taking, this study is done in Europe. And unlike Indian patients, the behavior of European or US patients is little different. They are very well informed, and they want to take, they are well informed, and at the same time they are aware about the side effects. They are aware about that, okay, painkillers do this kind of harm. Can I have some other treatment? Can I have other type of medicine? And therefore they go for these supportive kind of drugs. So that's where the chondroprotective drug, then intra-articular injections into the knee. Some patients, they take it. So all these were, if you have taken something like this before 3 months, then they were enrolled. But within 3 months of starting the trial, they were not enrolled. Why? Because some of these injections effect lasts longer, and in fact chondroprotective drugs also show their effect for a longer duration, say about 8 to 10 weeks, and to to reduce the bias that would come in because of these prior treatments, they have put this condition. Any new treatment or new OA, if some patient has started within 4 weeks preceding the enrollment, those patients were not enrolled. OTC, NSAID, and other CAM treatments, complementary alternative medicine, CAM, that has been, those patients also have been not, they did not include pregnancy, breastfeeding, did not include some blood coagulation disorders, intake of coagulation medications, acetyl salicylic acid, clopidogrel, all those were excluded. Invasive measures at affected joint during preceding enrollment. When we write inclusion criteria, it is based on the diagnostic parameters, and when we right, excluding criteria, certain confounding diseases and people who are taking other treatments which can interact or which can bias up. Then the inclusion in interventions. We are coming to the interventions. According to the American College
Dr. Asmita, you are going in and
of
out.
Rheumatology criteria.
Is anybody else experiencing that? Anybody who's on the call?
Yes, yes, same here.
Oh,
Is it okay?
yeah, you have been going a little in and out right now, like for about 3 minutes or so. Is your internet stable?
Okay.
Um,
Yeah, it is stable. Can
yeah, let's try again. No, you're frozen again.
you hear me now?
Yeah, yeah.
Uh, so let's go ahead. So the participants
Um,
received criteria. The patient suffering from. Is it okay?
no, you're freezing quite frequently. Do you want to try and move to another spot?
Oh,
Yeah, you want to move to another spot, maybe? Because
I can
others are
hear
also
you.
experiencing that. Yeah, I know,
Okay.
but you are freezing. Let's try again. Then otherwise we can try if you want to move a little, I don't know, different spot. We can try. It's freezing frequently.
Okay. Okay. The model conventional care with 15 treatment sessions and international consensus process of which included about 12 people from Ayurveda orthopedic expert and from 3 countries using the Delphi approach. So here you can see the treatment groups. Ayurveda treatment groups where there is manual treatment and massage. Tail was used. There were still freezing. I can see Pratibha.
Still freezing.
Okay. Okay.
Would you mind moving to another spot? Not moving the laptop, but you moving to like taking the laptop to another spot, like maybe at the back. I don't know. That might help.
Yeah, moving to another spot, I can. Generally, this is my comfort place, but
Yeah, it's going so well that we want
okay.
to hear you fully. The presentation is going so well that we want to hear you fully.
Is visible, and we can.
No, you're visible, but you are not audible.
Just a moment. Let me move to.
Another spot that really might help. Yes.
Yeah. I think this is better now.
Let's give it a shot.
Yeah, good. Yeah. So in this Ayurveda treatment group, there is manual knee massage with fermentation. They use, and then they selected some food items which are adapted to local food items commonly available in
Yeah, this
German
is a
grocery
good
stores.
suggestion.
The
Dr.
patients,
Asmita,
they use.
you want to switch off your video. That can improve the stream. So just try that because you're still cutting in and out. Let's try that, please. Yeah,
Sure.
please go ahead. Thank you.
Then there is ashwagandha and Bithania somnifera and Yogaraj Gugul. These were used as nutritional supplements, but for Ayurvedic people, these are the medicines. And Ayurvedic lifestyle advice, like me specific yoga posture, they have used 6 or 7 yogasanas, which were the patients were trained to do the correct postures and then daily self-applied knee massage. So this was Ayurvedic treatment group. Then there was a conventional treatment group, which they followed the quadricep muscle strengthening exercise. They followed knee-specific physiotherapy, including manual therapy, occupational therapy, and advice for individual home knee exercises. Then they also followed dietary advice for weight loss only for the overweight participants. So not for everybody, there was a diet restriction, but only for overweight participants. Long-term pain medication, according to current guidelines, was prescribed to these patients. And here, for Ayurveda group, we saw that Ashwagandha and Yogaraj Gugul were prescribed. For both the groups, certain things were kept common to avoid bias again. So rescue medication with a minimum of 3 gram paracetamol per day was allowed. In both the groups, suppose the pain is too much and with all this, whatever you are doing, it's not controllable, then definitely rescue medication, maximum of 3 grams of paracetamol per day was advised. In case of intolerance to paracetamol or non-response to paracetamol, topical or oral NSAID, like diclofenac sodium ointment was used, and oral ibuprofen up to maximum dose of 800 milligram per day was also suggested, after having consulted the study physician. Not on the own patient should take it, but patients were convinced to consult the physician, study physician, and then only take it. Use of other pain medication was discouraged, and participants were instructed to document the use of pain medication in the diaries which were provided to them. So at the time of recruitment, the patients were provided with diaries, and in that diary, every small point was written about, especially about the physiotherapy or self knee massage, whether they have done, the postures they have done or not, the diet, whether they have followed, and if they have taken any of the rescue medicine. So all that was definitely recorded. At the end of the trial, the diaries were taken back from the participants, and then the results were studied and the results were analyzed. So this is the consort guideline, the whole study in one go. At the time of enrollment, allocation, follow-up, and the last part, analysis, it was not, I could not fit it on this slide, and that's why this is half. But the fourth point is analysis. The link of the paper is shared. Please, you can check the whole consort's chart. What I want to point out here is, see the details, how well this has been recorded. Patients contacted 329, excluded 132 because they did not meet the inclusion criteria. So out of 132, 83 did not meet the inclusion criteria. 31 declined to participate. They said that we don't want to do it. And 18 did not give any reason, but they did not participate. So finally, the patients assessed for eligibility were 197. Out of that, 46 were excluded because they were interested, but they did not meet inclusion criteria. After that assessment, 5 patients declined to participate, and 6 patients just did not give any reasons, but they did not turn up. So randomly assigned patients were 151. Out of this, 1:1 allocation was done, equal allocation was there. So N is equal to 77 allocated to Ayurveda, and conventional care were 74. The 77 and 77 is not necessary. With the statistical appropriate kind of statistical methods, we can have such variation. At 6 weeks, now in the follow phase, 6 weeks, how many patients visited? 76. So 1 has dropped out. There is a personal reason. Out of 74, 71, 3 have dropped out. No reason given by by 2 people, but 1 person gave some reason. At 12 weeks, N is 76, personal reason 1. The same patient continued. At 12 weeks, here there are 71, they continued. Follow-up at 6 months, 76 continued for follow-up, and here 70 continued for follow-up. And at the analysis stage, in the Ayurveda group, there are 74 patients, and in the conventional treatment group, there are 70 patients. But for the final analysis, the patient number is, all the enrolled patients at baseline were considered. So treatments in both the groups were administered in 15 sessions over 12 weeks. We saw that 2 sessions per week in the first 3 weeks, 1 session per week in the from the week 4 to week 12, and with treatment time between 45 to 50 minutes for conventional treatment and 60 to 90 minutes for Ayurveda treatment per session. The treatment time was not matched because those are the standard practices from both the sciences. So the setting was real time setting, it was not adjusted or artificial setting. Outcomes were assessed using participant questionnaire. Outcomes were assessed at baseline, at 6 weeks and 12 weeks, and then 6th month and 12th month. So primary outcome was the change in Western Ontario and McMaster University osteoarthritis arthritis index after 12 weeks. This was the primary outcome. Secondary outcome included WOMAC subscales, pain disability index, pain experience scale, numeric rating scale for pain and sleep quality of life and mood, rescue medication use, and safety issues. So the primary outcome indicates the change in the disease, that is pathophysiology, and secondary outcomes indicate basically they indicate the quality of life, but not only one questionnaire. They have used all the available assessment scales to get a comprehensive picture. Adverse events were assessed by trial personnel in a standardized way at each visit. They were also documented by the participants in the diary. Participants, the additional thing in this study is participants documented their expectations for the treatment outcome at baseline. Why this was done? It's very interesting to note that whenever, for anybody who is new to Ayurveda, there is always more expectation, and that expectation gets converted into, we call it placebo. So placebo effect comes because there is higher expectation. If the results come good, we start saying wah wah wah, and if there is no expected result, then we have to condemn the things which we do or which we undertake. So for that, the expectations, what do you expect from this study? The participants have documented. They were asked to document, and they documented it. Here you can see at all the time points, within group differences and between group differences in the mean. So they have given all these indexes, Ayurveda and conventional treatment, what was the mean at confidence interval 95%. And here you can see the clear-cut differences in numbers also, Ayurveda and conventional treatments. Within the group, one patient to other patient. So there are 76 in Ayurveda group and 70 in the conventional group. All these statistical means are there, and the effect size, baseline week 12, the effect size is calculated, and the p-value is put to less than 0.001. WOMAC index progression is shown here in this graph. Ayurveda group, both the groups start at the same time point at baseline, and at week 6, at week 12, 6 months and 12 months, you can see that the graph is kind of similar, but yes, there is a little bit of difference. In the secondary outcomes also, I have shown you various scales, PDI, SES, so affective, sensory, then POMS, then PDI is pain disability index, and POMS is profile of mood status. So that depression, fatigue, vigor, anger, all these factors are available, and there is a system how to record that. I hope that this presentation is viewed or is listened to afterwards also by Ayurvedic physicians and students. So they will come to know that many of them are aware nowadays that there are different um, there are different measurement scales that those are available these days, and there is a method of how to record them, and it becomes very easy at the end of the study or after the study to analyze and bring it to the required statistical level, and so that the study's value increases. So instead of just going ahead with qualitative thinking that okay, this is better, this is good, these kind of scales should be used in studies when we are making some Ayurvedic interventions. So you can see week 6, week 12, 6 months, 12 months conventional treatment Ayurveda group, and between group at baseline and week 12. So here is the comparison, and these are the p values. So statistical analysis, one of the most important part of this study is a robust statistical design considering all the confounding factors like personal biases, drug biases, recruitment bias, physician bias, all types of biases are considered. And I selected this paper to present, but now I feel that I should have, requested a statistician to participate in this presentation along with me, who could have better explained this analysis. I want to highlight on 2 points of statistics. This was designed to have 80% power to detect a difference of 10-point improvement change to baseline on the WOMAC index after 12 weeks between both the groups. So see how am I going to say that my intervention is better than the conventional treatment? This particular statistical understanding they have put right up front. The study was designed to have this power 80% to detect difference of 10-point improvement both the sides, and a two-side t-test, and then pooled standard deviation 1/4 20, two-side t-test at 1/4 0.05. Now they have calculated that to achieve this 64 participants were needed. By taking dropouts into account, they have planned to include 74. They actually included 77 and 74, and they have included all at baseline for the analysis. So this is one of the important aspects while planning even a small study at master's level. The statisticians should be this much aware of the situations. Then missing data were imputed by maximum likelihood based regression methods. So this is something very typically statistical thing, that there are most of the times patients sometimes don't want to do. This is a long term study. They forget to do the knee massage. They don't want to do the yogasanas which have been told to them. They don't they miss out some of the doses, so there are missing data. And how to um, take cognizance of this missing data. So this technique is very important, and they have used that technique. So results are presented as adjusted WOMAC means per group with 95% confidence interval. These and therefore this study, the for selection of this study, when I read this paper a few years back, then again last year, and then again when it was going on that okay, we should present or discuss a paper, this paper came to my mind because of the precision of this paper, and that too the scientific or the statistical precision. They have considered sensitivity analysis to cover the placebo effect also, and the details you can read for yourself. So in the beginning only they have defined a decrease of at least 12 points as a treatment response for the main outcome parameter. So, and they are saying that this is a slightly stricter common response criteria. and the machine or the software which they used for statistical analysis was SPSS. Its details released 23, IBM, ARMOC, NY, USA, 2015. So how they analyze the data. They completed the study in January 2015, and they used the latest software to interpret or analyze the data. And here you can see all the characteristics. I know this is very small, but the paper is with you, so you can go back. Very neatly they have presented the numbers, and they are correlated with the conditions. The rescue medication used just for category 1 NSAID oral, total number of RM intakes, how many times in the whole study between for 1 year participants consumed rescue medicine, 676. RM taken in Ayurveda group are 91, and RM taken in conventional group is 585. This itself is representative of the treatment. I don't want to jump into conclusion effectiveness, but yes, the incidences are the numbers speak for themselves. So in the discussion part of this paper, the researchers have put down why and how very clearly. So discussion is the most important part of any research paper. Why they wanted to check the effectiveness of complex multimodal Ayurvedic treatment versus conventional treatment without disturbing both, that they have explained very clearly. And this treatment, somebody can question that Ayurvedic treatment is for 60 to 90 minutes. So the extended time period of 15 to 30 minutes might have contributed to better efficacy. So no, conventional treatment is given for 45 to 50 minutes. Let it remain at that, because that is the real original practice. And in Ayurveda treatment, depending on the patient's requirement, the constitution, other factors, we give that flexibility of 60 to 90 minutes, because it is a person-centric medicine that has been taken into account here, and that justification perfectly suits. I mean, no one can question that justification. They have addressed the issue of personalization using Delphi technique for standardization of Ayurvedic intervention. In Ayurveda also, everybody, we feel that, okay, we have been trained, but we really lack standardization. So if we want to give Janu Basti or Janu Abhyanga, then how long, from medial to lateral side stroke should be there, or from lateral to medial side? These things are not discussed and decided. If you go to a Panchakarma setup, you will find variations in all these practices. And that is why they have contacted, there are many Ayurvedic physicians, Vaidyas associated with this study, with the surgeons, Panchakarma therapists, physiotherapists, who are well qualified. This technique was also standardized for Ayurvedic intervention, and then it was applied. Same was followed for yoga postures. Of course, for yoga posture, there is a system of entering into asana and releasing the asana. But many times we find that people do as they want, and that was controlled in this particular study. Expectation bias was also controlled through the sensitivity analysis, as I said in the last statistical slide. Appropriate example of similar studies, like while discussing, some similar acupuncture trials have referred in the discussion. Why we did this, how a similar study has given a good result and our result matches with that, or if there is something different, then that also has been taken into account in the discussion. The discussion justified the open label approach against blinding. In case of Panchakarma, Abhyanga, in case of physiotherapy, you cannot just blind patients. So it was not necessary, not patients, I mean, both the things. So that kind of blinding was not applied here. It is a whole system study that also they have justified. And very important part, which is generally missing in many research publications, are limitations. So, why they excluded obesity? Why Ayurvedic patients allowed to take rescue medication coming from paracetamol or ibuprofen? Then full Ayurveda could not be used due to regulation of legal restrictions about use of medicines in Germany. That these are the limitations of the study, and they have been well thoroughly discussed in the discussion part. Um, Again, limitation of discussing the method to arrive at a choice of module for the individual. So they have also said that why see, Ayurveda comes from the personalized approach. We all know it, we all keep saying it, but how I select, as a Vaidya, I select this particular set of drugs and oils, or anything for lifestyle. Also, these dietary items. How do I come to that choice? This method, this intellectual method, has not been described here. That is a limitation of this study, and they have promised. The researchers have said that we will publish a separate paper showing the method to arrive at choice of Ayurvedic treatment. Scope for future publication from the data they have also mentioned here. So, coming to the last part of this paper and today's presentation, the results are, after 12 weeks of Ayurveda treatment, it led to significantly greater and clinically relevant improvement of knee osteoarthritis related complaints compared to the conventional guideline based care, with group differences maintained over 12 months. This is the achievement. So it could have been other way also. There could have been a equal effect which has sustained over 1 year, or there could have been less effect. But this trial was superiority trial. It was not equi-effective or inferiority trial design, and therefore the expected results are as expected. 151 participants were included. Changes of the WOMAC index from baseline to 12 weeks were more pronounced in the Ayurveda group. Mean difference is 61. Than in conventional group, mean difference is 32, resulting in a significant between group difference at p-value less than 0.001. That means applicability of the similar pattern in knee osteoarthritis patient is quite high. So that's what the results say. Participants in the Ayurveda group started with slightly lower mean WOMAC index values. Participants and physicians had higher expectations for Ayurveda than for conventional care, which was considered in sensitivity analysis. Average number of treatment sessions were 13.5 for Ayurveda and 14 for conventional participants. Mean treatment duration time was 67.8 and in the Ayurveda group, and 45.3 minutes in the conventional group. So these are the results, and the conclusions say that Ayurvedic treatment is beneficial in reducing knee osteoarthritis symptoms. Further studies should be conducted to confirm the magnitude of the effect and to clarify role of different treatment components and non-specific effects. They displayed that Ayurveda led to significant and clinically relevant improvements in disease-specific symptom reduction after 12 weeks of treatments as compared to conventional care, with most effects lasting over 12 months. And that is, I think that is what the patients want, because it reduces it reduces the demand of painkillers for them, paracetamol or ibugesic, whichever, or even local. So my impressions, or why I chose this study for presentation, is it is a very well planned study, well conducted study, and well reported study. It's as per the consort statement of study. Second thing is, while after reading this study, I felt that we have really put in practice all the Ayurveda principles in a standardized manner. This study has adhered to strict conduct, no compromise with science, also ethics. So it has maintained the scientific rigor. Ayurveda principle based study yet adopted to local legal framework. Some of the medicines, some of which we could have been used, we did not, and they did not, and then they have mentioned it very clearly. Team of Ayurveda, orthopedic surgeon, physiotherapists, nurses, statisticians, each perform their duties professionally, and that's why the results are very, I mean, the document is foolproof. The protocol amendment due to change in regulation was also mentioned in the study. You can go back and read on page 2. So, this is called meticulous data reporting. So, at some point, there was a change in regulation in 2011, which was implemented from 2012, and they had to incorporate it. And that was reported to the EC also. This is the fourth publication of this coming from this group. When they started the study, a review was published, then the complete protocol was published, interim analysis was published, and this is the publication for main study. If you go through the paper, you will find that it's very easy to understand. The language is simple. The diagrams and tables, they have put very clearly what they are checking for, and not too much jargon of difficult words and these things. And in the paper, there is this data, secondary data in the supplementary files. There you will find the actual Ayurvedic diet, the names of yogasanas, the oils. Similarly, you will also find the conventional treatment, how do they do this quadriceps training and standard knee protocol, all that. The whole information is concise and put in the secondary data file. People and scientists who are not aware about Ayurveda, one file talks about what Ayurveda is and what are Vata Pitta Kapha and how the Prakriti and other things are. It's a small narration, very well written, simple language. So that's where I feel that this paper has performed wonderfully well. And so I feel that such type of studies, after reading this paper some years back, I was thinking, like, is it really possible for us to do this kind of study? There were lots of funds, and therefore because of the funds people do it and all that. But then I feel that no, it's not like that. Funds will come, funds are there. Even the means which we have at our disposal, if our thought process is clear, and if we are interested to work as a team, not as an individual, work as a team, then definitely these kind of small studies are possible to perform. And we can also, Dr. Pratibha, since you are there and working with the whole group of CAM, and we just had a wonderful conference in Orlando, I think we can have multi-centric study by pulling the data which is coming in from the Ayurveda practitioners in US. We can identify from the East Coast, from the West Coast, from the center, some of the diseases, and maybe 1, 2, or 3 studies can be planned in this fashion. And therefore, when you requested me that this Times Journal Club can you do, I was interested in this particular aspect, whether if I read this paper to all the colleagues there, whether we can do something joint. And from Pune, Maharashtra DPU, and also from Ministry of Ayush, we are definitely eager to facilitate such activities. So
Sure,
that's all
certainly.
from my side.
If you like, you can stop sharing, Dr. Asmita, the screen.
Yes, I can.
Okay.
Yeah.
Thank you so much. This is really pioneering kind of publication. I wish there was more time for us to have Q&A and comments. If you are available and I'll connect with you offline, we can have part 2 of this in December, because I think this is
Okay.
a good paper to actually. I have maybe a dozen questions at this point, and comments also, because I'm also trying to critically look at all the parts, and that is the whole idea, that there's so much learning when we go to small sections and really look at. For example, I'll just tell you just a couple things very quickly. Dr. Sodhi, you can message me, I'll send you. um, so, for example, I was curious about the curve graph of the WOMAC index. What could be some
Hmm.
of the reasons? I did not see a commentary on that, because ideally we would like to see a progressive graph, for example.
Hmm.
So these are some of there are other such things throughout the paper, which particular intervention, there is a weighted analysis also, that this particular part of the intervention was more effective, kind of, whether it was yoga or whether it was something else. Those are the sort of subsets. I mean, overall, it's a great article, but it
Right.
will be lovely to have one session to just to, have a little deep down, dive down kind of analysis of this. So I'll connect with you offline. Is everybody interested in a part two? Just give me a thumbs up, and we can actually not have a new presentation for December. We can continue part two of this. All right. I have at least one yes. Anybody else? And I, of course, would love that, because this is a good
Yeah,
paper
sure.
to discuss. Okay. Okay, we have.
Sure, sure. We will need to decipher, because there are many, point by point you can discuss, and but it is very important to have a general overlook first, and then go into the details.
Absolutely.
And
Yeah.
basically, with the intention to, as I explained the disclaimer, the intention is to design better studies. Now, this
Yes.
study is done; it's over. It has been
Yes.
published. So, while
Yes.
designing new study on different diseases, and there are lots of diseases like irritable bowel syndrome, people are, they don't have anything on this now. So
Right.
for that, if we want to do it, let's work on it, and that's what it
Yes,
is.
yes, definitely, because 1 hour time is actually limited. And you did an amazing job of, breaking it down into sections, very organized. So it was a fantastic experience, and I'm sure anybody who is watching later on will also take away how to wear critical glasses and look at a study, the strengths. And, the good thing is the authors have themselves listed the limitations, which oftentimes authors
Yes.
forget to mention. So that also is a strength. So, yes, thank you. This was lovely. Thank you so much. And thank you so much to all who have attended. We are about to start our board meeting, so please feel free to leave. Our board members have started to join. Thank you so much. Have a great
Thank you,
night and have a great day,
Tejas.
Dr.
I'll leave
Asmita.
now. Take your leave.
Thank you.
Yeah. Bye
Thank you
bye,
so
and
much.
have a nice evening, I should say. For us,
Thank
it's a
you.
day.
Yes, thank you.
Bye.
Bye. All right. May I request